Thank you so much for having me today. Then I'm very much pleased and honored to speak about our South Korean experience to overcome this COVID-19 pandemic. Before it's epidemic, but now it strikes all over the world. So even our country, South Korea, had also difficulty to tackle these issues, but still contradictory, it can be role model for other affected country now, unfortunately or fortunately. So that happy to share the Korean experience today. Can you hear me well? Yeah. Let me know if I need to speak a bit louder, so that as you may know, the South Korea have flattened the cumulative epi curve quite well. That's why nowadays South Korea is featured as a role model to how to overcome the COVID pandemic. So as you can see, South Korea was the second affected country after China. However, compared to third, fourth, and fifth affected countries such as Italy, Spain, or the European and US countries, we, South Korea, contained that epidemics quite well. So that very low graph, or cumulative graph in terms of confirmed cases or in terms of death cases was happening here. This is the 1 week before that US is now skyrocketing. South Korea this is Washington Post sources for last day. So if we see the population weighted number, it's still US is not the highest in the world. European country is much more highest. Even though it's in terms of absolute number is high because of the large population size. Korea is here and just next to Japan. Some of you may know that the Korea has 50 million population, while Colorado states has 1/10 of that population, 5 million. Then population density is quite different. Maybe Korea has much more densely populated, much more close to each other, maybe 25 times more than Colorado. Then in incomes, we are a little bit richer than Spain, next to Spain, but not richer than Colorado average persons. And the median household income is higher in Colorado. That, in other words, you have more resources to tackle this COVID issues. If you compare the COVID, the current situation of as of yesterday, then this number of deaths is higher in our country. However, in terms of population standardized number, you are much higher, almost 10 times higher in Colorado. And also, severe cases is not equivalent to each other to compare. However, much more higher number is hospitalized in your country, and probably the more number of severely critically ill or severe cases there. And also, number of affected population is also 5 times bigger in Colorado compared to our countries. Then the main reason might be the number of tests. Active aggressive testing was previously debating issues. However, nowadays it's quite solved. Active testing is much better to guarantee the result. So as you can see, now almost 1% of the total population of Korea got tested because of any contact history. Now, we didn't do a screening test for all the older population, but if some has some contact history of an affected person, then we screened. Even we screened for the admitted whole pneumonia cases. That is a 3-digit number in the whole over the country. Then amongst that, we found out a super spreader, which turned out a super spreader later on, But we fortunately found out by this screening across admission cohort of the pneumonia, undetermined pneumonia or determined pneumonia. So in terms of population weighted percentage, we did 1%, while you are doing 0.5%. It's quite good, I think. Colorado has a quite higher number than other states in United States and other countries, I think. Let me introduce a little bit about the Korean healthcare system, especially focusing on financing structures. We are having totally out of coverage services, totally market services with a 100 direct payment from the out of pocket, but that's not high. But most generally, the layer one, 70 to 80% of cost is covered by the national health insurance. That financing was done by the premium basis. Then 20 to 30% of cost is shared by the co-payment from out of pocket as a co-payment or co-insurance. This is general structure. The first layer is much more typical health services. The second layer is little generous coverage for specific disease with TB or any more severe disease is covered more generously. Sometimes it's zero co-payment. And then we have last structure for the if the catastrophic payment appears, then government brought 50% of the catastrophic payment income loss for the lower than median income populations. Then for COVID, so we have been covering the co-payment by tax money. So in functionally, people affected does not need to pay any money, totally free. Two different governmental money can cover this COVID affected people. So we don't need to worry about the affordability issue in Korea. That's a little bit different issue aspect compared to United States. I wish Colorado can take over any affordability issue by government support or state support. So we had, if we zoom in the COVID affected stories, then we have we can make a five phases. Second phase is more likely surging. This is equivalent stage of Colorado, I think. During this stage, what we have done can be shared more focused way. Then let me start one by one. More likely, my story today will be published very soon this week or next week by Health System and Reform Journal. That will the feature more detailed one. That was written by me and my colleagues, and also the US colleague in Boston and then Chicago together to triangulate the audience perspective and US perspective together. So from the zero cases, no cases yet in South Korea, but China has epidemics. So we prepared the diagnostic capacity very early, partly because we had very painful memory of the MERS-CoV, another coronavirus in 2015, which was coming from the Middle East. That Middle East respiratory syndrome attacked hugely. Then our Korean population was having very higher fear at that time, and many government officials was punished after being affected that nosocomial infection most dominantly. Then that painful memory triggered this time to prepare a little earlier than other countries. So that was very helpful for containing this epidemic now. From the first phases, the sporadic case incidence phases, that is coming for almost 1 month during the January and February. Then while we are doing that, we did one very interesting aggressive activities, screening all the pneumonia admission patients, as I mentioned previously. The national screening for three-digit number of the pneumonia cases. Then amongst that, we found out 31st cases a patient who was super spreader who became spreading out almost to 60% of the whole population affected in Korea. Without doing this aggressive screening test, we found out probably very lately. Then after having that, we may have much higher number of epidemic than before than current. So more importantly, the second phase, surging phases, what we are doing is like this. We declared the highest level of epidemic crisis that after that declaration, Prime Minister read all the activity, the resource mobilization, and then new generation of any activities that can be divided into two main activities. One is prevention activity, and then the other is treatment activities. So let's see one by one. Further, the prevention activities, scale up measures to prevent community transmission that was done by this way. The local contact tracing and evaluation through local screening center for the potential affected cases. Then quarantine, and if it is affected, then isolation. Then physical distancing between people, especially for the potentially affected people. Then also at that time, the transmission mechanism was not fully discovered. So the physical distancing was not truly active at that time, but still people had very high level of fear based on 2015 MERS-CoV experience. So that even without banning from the government side for any restaurant or the bar, people are reducing a lot for the unnecessary or non-essential activities. So the halves or 1/3 of activity, social activity, was coming out. And for doing this active and local level, this district level contact tracing was done by the district level community health center officers who are local government officer, but not standardized EIS, epidemiology intelligence services officer as a central level officers, but they transiently, temporarily trained as local EIS officers who can implement the local contact tracing. So low and middle qualification EIS officer is a huge secret to be successfully contain the spread, I think. So we have 250 districts. So each district has a general population number 50,000 or 500,000. Then all the district has at least one health center. That health center is government health center. Then several 2-digit or 3-digit health center officers are working there. Their ordinary activities very diverse. However, during this epidemic period, many officers shifted from the original task to this local temporary EIS officer task. Then by doing this local EIS officers aggressive activity, we can do contact tracing a lot compared to standardized population weighted number. Then we did a lot of early testing so that once we found out any contacted person from the affected people, then that test was applied. So a lot of negative cases to assure he or she is not infected was going on. So that this number was going on and going on. If we compare this number with the US cases, US cases led the yellow and the orange colors. Orange color is positive result, and then yellow color is a negative result cases. By adding these two, is the number of tests. Number of tests is lower than Korea in terms of population weighted, but it is increasing over time. Nowadays, it's almost close to the population weighted number. But this lag left behind for a while, for several days. this number one is actually not the first cases. This number one is 100 cases. And after having 100 cases, then Korea is actively doing the test, while US didn't do it for several days. Almost 1 month later, it became 2/3 compared to Korea. Nowadays, 36 days later, it comes to similar amount. But this gap made a huge difference in terms of affected population number and then fatality and death number, I think. So the how to do that contact tracing in much in detail was published in this year early, the February, by one journal, also Public Health Journal. Then I will introduce a little bit briefly. The contact tracing is going like this. Investigation of the person who are affected, then whom he or she contacted as a potential spread, then contact list, and then where and when, and how much and how closely was recorded and then described. Then every contact history was compiled, and then it was publicized so that other people can see affected people visited that place. Then the other unaffected people can spare that space, that venue. So that way it was doing everyday activities. Every district level health center officers as a local EIS officers, they are doing this one. So patient interview was the primary sources for information, but also objective information was coming from the credit card utilization history, and also street closed cable TV, the CCTV information that was triangulated to find out any missing memory from the patient. Then after having triangulation, contact person are the local government restricted moving from the affected person, and also contacted person was also monitored by local EIS officers. 2 times every day, called him or her for any suspicious symptom onset or any isolation violation possibility, so that self-quarantine, self-isolation, or active monitoring was suggested by and also monitored by EIS, local EIS officers. And this is a sample of the contact tracing recording, the time versus time. So every 30 minutes, where he or she was there, then place, event, and the person who contacted at this time, all information was recorded. This is compiled not based on the smartphone app. This is compiled, described in the Excel sheet as a computer writing or handwriting. We utilize this contact history first, then another way of the cell phone-based GPS location. It is not precise, however, it can be a complementary sources to find out any missing information. The CCTV and the card transaction log is also utilized, as I mentioned. Everything pros and cons of utilizing this information is described here. Sometimes lag to get this information, but sometimes it's misclassified by having utilized someone else utilized this person's credit card or anything, some blind spot of the CCTV in the street or inside the building. That is a little bit limitation, but this objective finding information was hugely a complement. Let me skip this one, but you can see, I will share that slide. And another treatment activity redesigning is critical factors to contain the spread. And we established the triage center at the primary care center. Every district established at least one triage center, at also in a health center venue. So every person who are having fever or respiratory syndrome, the symptom, is not allowed to go directly to hospital or clinic. They need to visit triage center at the district level. Then at that triage centers, very much equipped, personally protection equipped, the health personnel are diagnosing this person to be affected or not for the COVID-19. Then if it's not that, then they can go to non-COVID the system. If they are affected, then they come to COVID system. We separated two different systems temporarily. So this is functionally two-tier system at the moment. For the tertiary care, one group of university hospitals are, or some university affiliated hospital was designated as a COVID center. At the same time, that university hospital have a non-COVID unit as well. So one single hospital is divided into two units. It's a strict barrier is there. That tertiary center needs a negative pressure room with the ICU and ventilator and ECMO, or all the needed the subspecialty staff. Then for the critically ill patients were admitted there, then secondary care center was designated to some good number of general hospitals. Once that is designated as COVID hospital, then that hospital cannot practice any non-COVID patient, or interchangeable nature is not allowed. So one single general hospital can be only COVID hospital or non-COVID hospital. So therefore, the designated as a COVID hospital can admit the COVID, not critically ill, but severe patient inside the hospital as admission cases. For mild to moderate cases, normally in that respiratory disease, we don't ask patient to be admitted. However, in this COVID-19, we asked them to be admitted, but not to the hospital bed, but a temporary non-hospital bed, which was formerly vocational refresher training center, or as a sort of dormitory structure. Public dormitory structure was transformed into similar to a hospital bed as a primary care hospital for observation only. Staff was dispatched to observe every contained the patient. If they are aggravated, they transferred to the secondary hospital or tertiary hospital. So we, at that time, we had a case mix, the severity mix from the Wuhan, China. There's 5% of affected people are the critically ill, then 15 to 20%, 10 to 15% is severely ill, and 80% is mild to moderately ill. So using that case mix, the severity mix, we prepare this tertiary, secondary, and primary bed for sufficiently hosting the patient safely in advance. This might be really crucial for Colorado. Preparing that admission capacity in advance might be really crucial. If it is overwhelmed, then maybe Italian cases and the Spain cases can be coming suddenly, so that nosocomial infection become huge after that. So it can be out of control. So early establishment or expansion of the observation bed, and then general hospital, and then critical ill tertiary hospital bed is really crucial. For doing this one, National Coordination Center was established from the National Medical Center. They can make a patient flow from even across the province, so that if some hospital is occupied too much, then we send that patient to other province, even from one epicenter to other city, other metropolitan city, to make a non-overwhelmed. This was working quite well. So prioritizing research in terms of bed or any etc., including the human resources we did, but the human resource reallocation was not really easy, but people, the health professionals voluntarily participated to gather to the epicenter. You may know that Daegu City is a big epicenter. And then people, the doctors and nurses gathered to that center. So primarily, this phase is rapidly but smoothly. We prioritize many resources compared to non-COVID condition. We prioritize COVID condition compared to personal privacy. We utilize much more public information safety basis using private information to save the people's life. Then we utilize the diagnostic test very aggressively. Rather than symptomatic cases of application, we applied all contact tracing cases for diagnostic test. Nowadays, the JAMA introduced the multiple, one single test for multiple person for the screening test. Then if there is a positive cases, then every single personal specimen can be reassessed, then finding out the patient. By screening out that quickly by that mass screening, that can be another invention recently. Even at that time, we didn't use it. Yeah, you can apply that. Then the other, I can probably skip. Then third paces, then that was actually the decreasing paces. However, during this time, huge chaos was coming out, especially for masks. So people would like to wear mask, but mask production was short, so that many people cannot buy a mask. And also, economic downturn came out, even though South Korean government didn't do social distancing as a forceful way, but people reduced their activities, so that economic downturn came out, and people, especially small business people, are having very economically hardship there. So these two are very much, health risk is reduced, but non-health risk, economic risk is huge. So now it is plateau time, quite much more stabilized than before, even it is not finished yet. But the two issues still going on, but it become much more smoother than before. Masks, it become public goods. We increase the production capacity so that we can provide 2 masks per week per every single person. So this is now highly regulated, the private good, as if it is public good. So people can only buy 2 masks per week. So using the drug utilization review system, that is actually a system to prevent any overlapping of drug prescription for each single person. That was utilized for mask overlapping, so that the almost rationing for mask was quite smoothly done now. Then to cover the economic shock, the South Korean government introduced the basic income for overcoming disaster-related economic shock, paying everybody for some amount of money. If I review priority setting practice in Korea, then quite well managed for this green listed. Then not well managed, but quite not bad managed was like the economic shock management, and then privacy management, PP management, etc. Maybe I can skip this one. As a last part, I can quickly introduce what information was released from the KCDC to be informed every day. Press reporters are getting this information every day. So I didn't translate all the information at now, but I would like to show how much information was released every day. So this is the domestic confirmed cases everyday update. So that I saw Colorado webpage show that every day updated. So the similar information was giving from the first day of the affected cases for last 3 or 4 months. We did it every day. Then this is for the information of the new cases, daily new cases, and then the blue line is new cases. Then the gray line is the releasing from the isolation. So isolation releasing is higher, and then Now the new cases decreasing, so the isolation, this isolation number is also decreasing. So this is accumulate number of real isolation number, that's the orange line. Then accumulate number of the new cases is a gray bar. Then dark blue bar is this isolation released from the admitted. This is province across nation, the province level statistics. We disclose this day every day. This information was seen in Colorado website. Also, province across the cluster, single cluster, or any potential, any cluster natured cases was disclosed as well. Then another information is district level new cases and then accumulated cases was informed. For Daegu epicenter, that was here. Then yellow line is the accumulated cases. Now it become decreasing in terms of increasing speed. The new cases were quite decreased now. Epicenter become quite stabilized. Then another epicenter is also similar pattern. Then now it's a Seoul metropolitan area. New cases increasing now, so the accumulated cases increasing over time. And then this is the province embracing Seoul capital. That's similar to the New York State. It's ever increasing now, even though number is not high, but still new cases continuously coming out. Then the other information, except these four areas, the other areas, some is like this. Every day is new cases here. This purple color is imported cases from the incoming travelers. Nowadays it's increasing. This is increasing as an accumulated number. It's the imported cases from other countries such as US and Europe. And the overseas flow statistics is also disclosed every day. Then demographic factor for age-specific incidence rate, and then age-specific death rate is disclosed. Incidence rate for 10,000 people disclosing as well. Then severe patient information, 34 severe cases, 46 critically ill patient information is giving. And the daily death, fatality rate is red color, 1.8 now. It's lower than US and Europe. And then the single bar is absolute number. It's less than 10 every day now. This is the infection path. Now, recent 2 weeks show the half of that is the imported cases from incoming travelers. And another globally confirmed cases from other countries informed by the press release. Then National Code of Conduct, what should be done to the list for every laypersons. Then let me say to the Colorado colleagues, so as a 3 take-home messages, like if you can imagine as a source or the way of solving the problem, please do whatever you can imagine that will be helpful for your solving, such as counting each cases and the meeting person, the contacted person. Counting is the basis. The next one is there's no too late. You should do as soon as possible to catch up. Then it will be better. Then also I would like to recommend the never give up. So I wish you can be helpful by this information sharing. Let me finish that.
Wonderful. Thank you so much for your presentation, Juhwan. So we have about a little bit more than 20 minutes at this point that we can open it up for discussion and questions and answers. So if you have questions, you can put them into the chat, or you can also unmute yourself. I think we're a small enough group that we can open it up for questions as well that way. Okay, and I'll keep track of the chat. Juhwan, I don't know, are you able to see the chat, or I can read it off to you if you prefer? I can.
Oh, yep, I can read it. Yep.
Okay.
And has there been a relaxation of social distancing, and how is that done? That's one question. And did South Korea have a shelter in place, order, place order at any point in place besides social distancing? Yep, happy to respond that. Regarding social distancing, that's quite different from European or US history of the social distancing. While I'm mentioning the surging phases, that was the epidemic and the huge risk phases in our country. At that time, social distancing was not the main policy. Government didn't ban any social activities. People just do it, just did it by their own decision. So restaurants were open, still open actually. The restaurant were open, and bars open, every public cinema was open, but people reduced their coming to that place so that the visiting number was halved or 1/3, even lower than 1/3 now. But still, banning is not happening at all. Also, school was actually at that time, it's a winter break time, normally winter break time at the time, but we extended school closure for more. So currently, school was opened, but it was opened only by the distant learning basis, not physical opening, except that school closure issues, most of social distancing was very soft than US cases. That's quite a different one. So but effect might be not truly different because people voluntarily reduce a lot of activities. But that soft social distancing may reduce economic impact. Probably the U.S. economic impact is much huger. The too many number of unemployment or small business bankruptcy or anything is happening now. But in Korea, even they had also similar difficulties, but the level of difficulty is little smaller than US cases at the moment. So that's the things we can. But interestingly, these days, social distancing was encouraged from the government side. So the purpose of encouraging social distancing is we want to sustain our ordinary life with a quite reasonable level of physical distancing, so that sustainable physical distancing is a purpose, not a strict distancing. So that might be interesting point to follow. But I think Colorado would be a little difficult to do that at the moment because already epidemic is huger than Korea. So that you need to contain by two strategic way, by clinical capacity establishment and then aggressive active contact tracing. Once you can contain a little bit, once new cases coming down, then you can release social distancing from ban to little voluntary ways. That would reduce the economic the risk impact. Then, during that time, the question was coming quite well. The shelters. Nowadays, the shelter policy was changed over time, but at the surging time, shelter was provided for the affected person only. Once mild to moderate symptom but affected, then they are admitted to the shelter. That's not clinical facility, that's a dormitory, public dormitory. But doctors and nurses are dispatched to observe their condition if they become aggravated or not. That shelter was supported by totally full payment by the government. People doesn't need to pay. But for the contact tracing purpose, we didn't provide any shelter at that time. But recently, the isolation at their home, or if incoming traveler from outside who doesn't have home in Korea, then we provide a temporary home for 2 weeks during the quarantine time. then we provide food and then stuff, daily stuff. Then they can use that without going out, but they need to be strictly inside that facility. This is a very strong law now. So that if they violate that law, they can be fined and they can be punished. Shelter is provided for the person who doesn't have home at South Korea, but if they have a home, then they are isolated at their home, but they should be home. For the third one, lay media is now reporting the there are 51 cases of reactivation of the virus in patients previously thought cured in South Korea. Do you know if there are plans to change any of the method to control that previously been used? Yeah, actually, this is new issues. Some of the reactivation or some cases, we need to clinically assess what's the fundamental mechanism of this one. So this is actually potentially huge issues. You may remember that some infectious disease epidemiologists said, and then Swedish country accepts some kind of herd immunity issues. So once we see scientifically, everybody is affected and cured, then no reactivation, and then they can get a lifetime permanent immunity, then we can expect herd immunity. However, there is no strong scientific evidence yet. So the herd immunity strategy might be very dangerous at the moment. So this 51 cases might be warning like toward that stories. So we don't know the true mechanism of this one. Maybe one possible mechanism is not truly cured but misdiagnosed, or truly cured but reactivated. If it is really reactivated, it means no immunity, permanent immunity works. So it's really dangerous sign. We need to investigate more. So I have no more the knowledge about this at the moment. Then next one is, do you have any measure of how much personnel you had available for case investigation and contact notification? Number of staff per capita. Oh, yeah, that's very important number. I didn't have that number very precisely. However, rough estimation is every district, which is 250 district in Korea, cover one district cover 50 to 500,000 population in their district, and each district has around 100 health center officers. Some of them are clinical officers, some of them are administrative officers, different qualification and different ordinary role, but almost all of them are serving as a local quarantine EIS officer at the moment. So that maybe I can roughly say 100 or 200 person per each district cover 5,000 to 500,000 lay population, but not all population are the eligible population of as a contact person. So that very much a smaller number of that contact history population is covered by these persons. So still, we was able to handle that by this. They might be overloaded, but they were able to handle it. So this information was very important to Colorado, I think. Then I think you need to, one of my co-authors of my paper in the United States, who are medical doctors and primary care doctors in Boston, suggested that unemployed workforces in US might be one of the big candidates to do this one. Especially quite good education qualification people, but temporarily fired or the unemployed now, then suddenly you can actively recruit all of them or many of them, and then train how to do that. Then actually the contact tracing is not really rocket science. The knowledge is necessary. Counting based, who met whom and what, where, when, that information was compiled in the Excel sheet. So that information is necessary, so that quite well-educated people or mid-educated people can do that very well. Then next question is the detailed case interviews with review of phone or credit cards, TV resource systems, incredibly labor intensive. Who did this work? Yeah, that's right. It's really labor intensive. As I mentioned, this was done by local EIS officer who were formerly health center staff, currently shifted the task into these EIS officers. So I already suggested unemployed quite well qualified, educated people can be actively, aggressively trained for doing this job at the moment. It is because it is really labor intensive. Calling, interviewing the affected person, who met whom, then check it by credit card information, by police coordination, and also CCTV. CCTV checking is really a time intensive one, and also calling them if they are self-quarantine for isolation quarantine for 2 weeks, then every day, 2 times call for everyone to see any new symptom is coming out, or every single person absolutely confined in their home. Nowadays, we developed a smartphone application so that self-reported application information was coming out. So telephone, twice telephone a day, now complimentary, but still it is utilized. If there is someone who are gaming, putting their cell phone inside the room but going out, that can be detected by the phone call. If when officers call the phone but they don't receive it and the landline phone, then still that is punished as well. So yeah, this is really labor intensive work. Next question is, can you share any resources for establishing and running the dormitory structure you mentioned? Or can you go into more details on what this look like and how they manage it? And we are considering this type of structure for patients experiencing homelessness. And then do you have any suggestion for adapting this to the Colorado context? Yeah, I have much detailed context of Colorado yet, but from the Korean perspective, we established urgently 16 dormitory, public dormitory, such as my university has one refresher training dormitory center near the Daegu area, which is far from Seoul capital. That is a huge accommodation center for the refresher training. But that was shifted to become a non-clinical temporary primary care observation unit, as if it is admitted unit. So that several hundred room was utilized for every single room has for every one single person who are affected, but no severe symptom, mild to moderate symptom. Then every time the dispatched medical doctor and nurses are calling inside the room, then how is going and what's the symptom and how is feeling. So it is closely monitored. And if anyone who are a little bit aggravated, then arranged to become hospitalized in the secondary general hospital. So this is quite safe. So that that was a 16 institution in terms of dormitory number. The prepared number of bed is roughly 4,000. And then after that, we prior to the epidemic in Daegu City, we prepared this about 4,000 bed in advance. Then later on, the affected number of people are 4,800 in that city epicenter. So it's a little more than that. But ongoing general hospital and the university hospital, including this dormitory structure, then it can be contained mostly within Daegu City. And a small number of critically ill patients were transferred to other provinces, including Seoul's capital. So you might be utilizing any sort of public dormitory. Probably university dormitory was vacant at the moment, as I know. So that can be also transformed into transient 1 or 2 months or some months to be contained for this purpose. And you need to dispatch nurses or doctors to observe. If it is ignored, some of the death cases can be coming out in that dormitory. So please be cautious. And definitely PPE is very important. Barrier should be there, even though mild or moderate symptoms, they can be still transmissible. And then next question is, how much do you think the electronic method of case investigation, phone tracking, credit card, the CCTV compared to the traditional interview process? Yeah, initially we began with the classic traditional method. However, it become evolved and evolved, but still we are keeping traditional method, partly because app application, for example, self-reporting of anything of the Google-based position GPS service can be applied, but the false information might be a huge issue. So that's why every single check by manual way is still preferred in Korea. However, in United States, if it is overwhelmed, you can utilize more IT bases, and also you are much more IT strongest countries, so that you can develop a little more the mass scale approaching. So I don't discourage it to utilize more modern IT based approaching, but still preciseness issue is should be kept, I think. And if we go too much for the IT based one, privacy issue may comes. If convenience issue comes too much, then privacy issue might be big scandal, so that even people accept loss of some privacy, but still I wish you can handle that quite balanced. Our National Council of Human Rights warned too much private information disclosing is not encouraged. Then what are South Korea's preparation for the next pandemic after this experience? Yeah, this is really important question. We have been starting to make how to develop treatment capacity, or how to develop the vaccination capacity for this MERS-CoV, the COVID-19, but also for the next virus or next pandemic of next pathogen. We didn't specifically establish any institution for that. However, we know that we need to develop this one. Otherwise, next virus will do the same things. But based on our previous painful memory of the MERS-CoV in 2015, we prepared this COVID-19 while China had an epidemic, but Korea didn't have it. Still, we actively did many things, and finally, we are quite successful to contain it. So, yeah, definitely we are going to prepare the next epidemic, but we didn't have specific strategy yet. And what were the risk factors? Gender, age, underlying comorbidity, stay in nursing homes for mortality in the South Korean population, as it seems to be differ by country, depending on underlying demographics and socioeconomic intergenerational family structure. Yeah, that's a good question. In terms of gender, it's still not same, but gender is not huge issue, but age is huge, is more senior. This is quite similar to US. 80 plus has a severe fatality, then 70 is the next severe, and then 60 is the next, 50 next. For over 40, quite smaller. Below 40 is almost no deaths, but 20 has a highest incidence, but without death cases. Then also similarity might be comorbidity cases, especially for hypertension cases. It's a huge, and also even well-controlled hypertension has a higher probability to be die, and also diabetes and other cancer or any sort of comorbidity is a highly risk factor. And staying at the long-term facility like a nursing home in US, our cluster is much more like this nursing home style structure in Korea. We didn't have good experience to contain or prevent that the nursing home based deaths. Huge cluster is nursing home based. Still, nursing home based people are much more marginalized and the aged people, and they are the population who died mostly. So we didn't have very good strategy to reduce that yet. So this might be a similar situation between the two countries. Then, yeah, I finished it.
Great. Looks like we've got a couple people. We're getting close to time to wrapping up, so we can see if there are any final questions for you. Otherwise, I expect we might have questions in the future. And I know that I just wanted to let anybody who joined after the intro know that we will be recording the presentation in case you missed part of it at the beginning. And just thank you, Juhwan, for sharing that presentation and for tailoring it to Colorado. It's really, we really appreciate it. And I know we have another meeting that we'll be switching over to. So thank you all for joining us on this seminar. And if you do have questions or if you want to follow up, we can, you can go ahead and reach out to me and I can pass those on to you, Juhwan. So again, thank you so much for your time. And thank you everybody for all the work that you're doing.
Thank you so much for having me today.